Hello, good evening, everybody, and thank you for coming out tonight or staying at home and watching on your computer. But my name is Brian Seifman from Michigan Institute of Urology, and we're going to talk about understanding and treating benign enlargement of the prostate, or some people call it BPH. So just a little bit about myself. I was born and raised in Michigan, went to North Farmington High School, went to University of Michigan for undergraduate, Wayne State for medical school. Then I did my residency and fellowship both at the University of Michigan as well. So I did general urology, and then my fellowship was in endourology, which is basically doing minimally invasive surgery as well as for stones as well as cancer. So I have two offices that I go to. One is in West Bloomfield, and then the other one is in Rochester Hills. So what is BPH? So BPH, or benign prostatic hyperplasia, is just basically an enlarged prostate. It is not cancerous, it's very treatable, and it's incredibly common. So if you look at people who are roughly age 50 to 60, about 50% of those people will have some symptoms of BPH. And as men get older, their prostates tend to get bigger, and as it does, they're much more even likely to get symptoms. So if patients 80 and older, up to about 90% will have some urinary symptoms. Why exactly do men get it? Nobody really knows. Maybe it's due to changes in sex hormones, but clearly as men do get older, their prostates get bigger. Now, not everybody who's in a enlarged prostate will have urinary symptoms, but obviously it can be very common. So how does the enlarged prostate affect your bladder? I don't have a pointer, but you can see from the two pictures. So one shows a normal prostate with the bladder behind it with a little bit of urine in there. And basically in that picture, it shows that the urine is coming out directly through the bladder, through the urethra. Now, the picture that you're seeing on your right shows an enlarged prostate. And what it's doing is it's compressing the urethra or blocking the opening. What that can do is it can result in urine basically retained in the bladder, which can give more urinary symptoms. So what kind of symptoms do people get who have benign enlargement of the prostate? A sudden recurrent urge to urinate, difficulty starting their urinary flow, or what we call hesitancy. So men go to the bathroom, they stand there, they wait, and then eventually it starts coming out. An interrupted, slow or weak urine stream, going frequently during the day or at night, having to strain to get the urine started, not emptying the bladder completely, and potentially even urinary leakage. So what kind of side effects does BPH cause besides those urinary symptoms? Well, if you're not emptying your bladder completely and urine is just sitting in the bladder, you get stasis of urine. If you have stasis of the urine, it's not emptying, you can get urinary tract infections because bacteria can start to grow in this pool of urine. Bladder stones can also occur because the urine has crystals in it. Those crystals can start to coalesce and form, as they get larger, then they end up forming stones. If this is not treated over the long term and you're retaining more and more urine in your bladder, you can actually get kidney failure. And the reason why, the reason why that occurs is because as the urine's backing up in the bladder, it can actually back up so much that it starts backing up into the kidneys, and that can cause kidney failure from that. Again, if not emptying very well, you can get urinary leakage or incontinence. And if it goes on long enough that you can't empty your bladder, eventually the bladder can actually be damaged so much so that it can't urinate on its own and it's no longer contracting. That in that situation, a catheter or some way of draining the bladder would be necessary. Now, it is important to point out that BPH has nothing to do with cancer. They're two totally separate things. You can have a big prostate causing urinary symptoms that is not cancerous. You can have a small prostate with no symptoms and have cancer. So they're totally unrelated. So what kind of things do we use to diagnose enlarged prostate? So one is just doing an exam of your prostate. the exam is one way to also screen for prostate cancer. So as long as there's no lumps or bumps on the prostate, that's usually one good way of checking for things. Also on the exam, you can get an estimate of how big the prostate actually is. We usually will check a PSA, which is the blood test that screens for prostate cancer. We'll check your urine, make sure there's no blood or infection. And then the easiest test to do is doing a bladder scan, which is basically a small ultrasound that it's done of the bladder after you urinate, so we can determine how much urine there still is left in the bladder. Then if we're going on to further diagnosis testing, the two easiest ways to check it, or the two main tests, are called a urocuff. A urocuff basically is where you come in with a full bladder. You'll actually urinate into a machine that actually can measure how much pressure with which you urinate, which tells us how hard is your bladder working. And also it tells us how fast is the stream coming out. So we do have normal parameters, and it can tell us, does it look like your bladder is working so hard that it can't compensate, and that's why the urine stream is coming out very slowly. Urodynamics are a little bit more advanced than doing a urocuff. Urodynamics is where we take a small catheter, put it into the bladder itself, and then we fill the bladder while and measure the pressure in your bladder as it's filling. This can tell us, are you having bladder spasms or bladder contractions? Do you have a normal storage capacity? Are your bladder pressures okay that way? And then we actually have you urinate with the catheter in place, and it can measure the pressure when you're urinating. So the urocuff is simpler, it's easier to do, it's non-invasive. Urodynamics certainly gives more information, but it is an invasive test to do. Further testing in order to examine the prostate is to actually do a cystoscopy, where we're actually looking inside the urethra at the prostate itself. So we take a small flexible camera, we use some lidocaine jelly, which helps to anesthetize the urethra. And by using this camera, we can actually see what the prostate anatomy looks like. So is it just growing on the sides? Is it growing on the floor? Something called the median lobe, that's on the floor of the prostate. And these things can help us to determine what's the best treatment for you at that point. Furthermore, looking in the bladder, we want to see, do you have a thickened bladder wall? So that can help us to tell if your bladder is working hard to get the urine out. Are there any stones or tumors in the bladder? And that can also only be seen with the scope. Other testing that we'll often do too is an ultrasound of the prostate. So the ultrasound goes into the rectum and takes pictures of the prostate. The ultrasound is important to know the exact size, because again, that can change how we, what options there will be available to you, which we'll get to in a moment. And then sometimes we'll do a biopsy of the prostate if there's concern for cancer. So concerns for cancer will be based on either the abdominal exam or an elevated PSA. So from time to time, there will be questions. I'll try to get to them as we go along. I did see that someone did ask a question about why would you do a urocuff versus the other. My preference would be to do a urocuff. I think it's easier and it's less invasive. If, let's say we did a procedure, things aren't improved, or there's a very confusing picture in terms of, does it look like it's BPH? Does it look like an overactive bladder? Are you not able to urinate at all? Those kinds of things would be better suited for urodynamics, because then you can see what the bladder pressures actually are. Can the bladder contract, and things along those lines. And then one other quick question just came in. So can an MRI adequately inspect the bladder and the prostate? Depends exactly what you're looking for. So I would not use an MRI to evaluate the bladder. The MRI is not a functional test, so it can't tell us how good does your bladder work. MRIs are good at getting the size of the prostate, and they can also detect about 85% of intermediate or high risk areas that could be concerning for cancer. Not a typical thing that we would do just for an enlargement of the prostate but more if we're looking for cancer. So now that we figured out that you do have BPH and you have symptoms, how can we treat it? So there's different ways of doing it. There's lifestyle changes, medications, things to avoid and things to take, and then there's lots of procedures. So starting with lifestyle changes. So if you're not emptying your bladder, one option is after you urinate, you pause, you wait. Sometimes it's 15, 20 minutes later, you go back and try and urinate again, just to keep completely empty. If you're getting up a lot at night to urinate, avoiding liquids after dinner. So we're usually an hour and a half to 2 hours before going to bed. Try and have less urine in your bladder when you go to sleep. And then there's lots of foods and drinks that you can avoid. Coffee, tea, carbonated drinks. Even without caffeine, coffee and tea will have some irritants in them that will still make you feel like you have to go to the bathroom, even if it's decaf. Alcohol can act as a diuretic. So you drink a little bit of fluid, even a shot of alcohol, you're going to make more urine than what is in that shot. Spicy foods, tomato-based products, chocolate, they can all be irritating to the prostate itself and the bladder, which makes you go more often. Some other medications that can potentially be worse for people that have enlarged prostates are a lot of antihistamines, like Benadryl, Allegro, Zyrtec, Zyrtec D in particular, or Sudafed. All these things basically counteract some of the medications that we use, and they act on the prostate, can actually tighten up some of the muscles in the prostate, or the smooth muscle in the prostate, making it more hard to urinate. Valium acts as a muscle relaxant, which can also relax the bladder. Narcotics can do the same thing, as well as cause constipation, which can also affect how you urinate. And just be aware of the over-the-counter medications that claim to help the prostate or bladder. Frankly, most of them don't work. And most of them have not been studied in any kind of double-blinded, placebo-controlled trial. And if they have, most of them have shown that they really don't do very much. Okay, so just a couple questions here before we go on to other medications. How often should you have a PSA test, and how accurate is the testing? Depends on your age. What is your PSA to start with? So if you have an elevated PSA, we may be checking it every 6 months. Depends on how quickly it's rising, how big is your prostate, because the bigger your prostate is, the higher PSA can be. And how accurate it is, that's very difficult to answer, and that's probably not easy to answer on this type of webinar, but there's lots of factors that go into PSA and risk of cancer. PSA velocity, or the rate of rise, PSA density, meaning the size of your prostate. There's free PSA, there's iso PSA, there's other ways that we can look at to try to determine your risk, which will also tell us how often you need to have your PSA checked. And then would you expect BPH symptoms to get worse over time? It usually does, because the prostate usually gets bigger. Symptoms that kind of come and go in waves. So meaning that you could have a month of bad symptoms, a couple months of good, a couple months of bad, a couple months of good, but over time, it's usually expected to slowly get worse. Okay, so some medications that are used to treat BPH. So alpha blockers. These would be drugs like Flomax, Rapaflo, Uroxetrol, Hytrin, Cardura. Those are the brand names, the generic names: tamsulosin, silodosin, alfuzosin, terazosin, doxazosin. So if it ends in osin, probably used to treat your prostate. But what these basically do is they relax the bladder in the prostate, the smooth muscle in those areas of the bladder, neck, and prostate. And what it does is it doesn't actually shrink your prostate, but by relaxing those smooth muscles, it makes it easier to urinate to get a better flow. The 5-alpha reductase inhibitors are like Proscar, finasteride, Avodart, dutasteride. What they do is they can actually shrink your prostate, but it does take time to do so. So I would usually say, within 6 months, you should be seeing a decent effect from it, though your improvement in urinary symptoms is going to be much more with alpha blockers than it is with 5-alpha reductase inhibitors. So most people start with alpha blockers as their first line of treatment. So when do we do procedures? Well, if your medications aren't working for you, if you don't want to take any medication, so some people will have side effects from medications that they find obtrusive, and or we have testing that shows that, your bladder is really obstructed, prostate's very large, you have a lot of thickened muscle fibers, and that can sometimes be a reason to do a procedure because medications may simply not work well enough for you. Most of the procedures are covered. We would check with your insurance carrier first to make sure that you're not stuck with a large bill because something is not covered. Most insurances do cover most procedures, though. So one treatment option is something called the Urolift. A lot of people have seen this on TV of recent. There's been a lot of ads for it. And basically, I would consider Urolift, it's a minimally invasive procedure. And the way that it works is it basically pulls the tissue out of the way. So some people say it's kind of like a curtain where the implant pulls back on the sides of the prostate. One advantage of it is that it's outpatient, so you do not have to stay overnight. Usually it's done under IV sedation, kind of like a colonoscopy. And 90% of people do not need a catheter to go home with. So you can see in the 3 steps here, the first one is just looking into the bladder. In step 2, there's a clip or a staple that kind of goes through the prostate. It anchors on the prostate caps on the outside. And then there's another trigger on the device itself that locks it in place on the inside. And so depending on the size of the prostate, in this picture, they have 4 clips that are placed. 4 is probably the most common number that is used. So some of the risks or side effects that, typically the Urolift does not have any ejaculatory dysfunction. Usually tell people to take it easy for about a week because you can see some blood in the urine that can stay around for a week. There can be sometimes some burning urination or frequency of urination as well. Now, if cancer is an issue, there is no prostate tissue that's removed, so there's no testing for cancer that would be done with this procedure. So another minimally invasive treatment will be something called Rezum. So Rezum is actually done in the office, and it basically uses steam or water vapor to basically shrink the prostate to correct the obstruction. So how it works is when we look into the prostate or through the urethra, there's actually a needle that goes into the prostate. It injects the steam and treatments. Each treatment is about 9 seconds apart, or 9 seconds. And then we do multiple treatments depending on the size of the prostate. So over time, what that steam does, it actually destroys this prostate tissue, and then the prostate will actually shrink down and open up. So now it does take a little bit of time for this to start to work because it takes time for the prostate to actually shrink down and for the body to absorb it. So most patients will begin to experience some relief in about 2 weeks, but it can take up to 3 months to get the maximum effect. So some of the benefits of it is that it's local anesthesia is used, it's done in the office. You do need a catheter for a few days after the procedure because the steam can actually initially cause some swelling in the prostate, and we want to make sure you're still able to urinate afterward. Possible risk of urinary tract infection, which I would say is probably true for really any procedure that we do. Anything that's invasive has always a risk of having infection. Short-term urinary urgency and frequency, I think it's going to be true for just about everything. But the advantage of this is that it's done in the office. Prostate tissue is actually destroyed and opens up the channel that way. So CoreTherm is another type of treatment, usually for larger prostates. And CoreTherm is actually using a microwave generated heat to actually destroy prostate tissue. So when you're doing a CoreTherm, they actually measure the temperature in the prostate and measure the blood flow into the prostate, because the more blood flow that is there, the more it cools the tissue. And if it's cooling the tissue, it doesn't destroy it as much. So how this works is that there's continuously monitoring the temperature and blood flow in the prostate. You actually put a catheter into the bladder with a balloon on the end, so it keeps it in place. And then there's a microwave generator on it. The microwave generator has a probe, so it sends real-time data to the screen, so we know how long to treat the area for and how high the temperatures are getting. So that way we can also protect the urethra as well. So again, this is thought to be, or planned to be, a one-time treatment. It does take a little bit more time for the prostate to actually shrink down. I wouldn't say it takes up to 6 months to feel the full effect. That's what the company would say, but I would say within 3 to 4 months, most people are doing very well and have most of their improvement done. This is done under local anesthesia, and it's also done in the office. There's a catheter. Now, the company may say the catheter is needed for 3 to 6 weeks. It's probably more like 1 to 2 weeks, because again, there could be some swelling and irritation in the prostate that takes a little bit of time for it to go away. And we want to make sure you're able to urinate when the catheter comes out. And again, I would say there's still temporary discomfort, urgency, once the catheter comes out. It typically goes away within a couple weeks. So laser therapies, there's different types of lasers. One mentioning here is called green light. The green light basically evaporates prostate tissue. So it's similar to what we'll get to later called the TURP, which is a resection of the prostate tissue. But here what the laser does is, in the diagram, if you can see it, there's a green light that's basically being pointed at the prostate tissue. And so the laser actually will evaporate the tissue rather than actually scraping it. So this works pretty well for small to medium-sized prostates. It is done under general anesthesia. The vapor light removes the excess tissue. The idea is that with the laser, you might get a faster recovery and quicker healing. Now, there's no prostate tissue removed, so it's not sent for any kind of pathologic diagnosis. I'd say typically it's not an overnight stay, but you're going to need a catheter usually for 1 night. It can have some retrograde ejaculation, because when you do this, you open up the bladder neck. So when you have an orgasm, sometimes no fluid will come out. It's not a medical concern, but if people aren't aware of that, they get very concerned when nothing comes out. You can see blood in the urine for 1 or 2 weeks afterward. And sometimes you can get burning in the urination that can last for a few weeks, because sometimes the laser might have a little bit of a deeper treatment area than what you can see visually. And if it goes, the deeper it gets, the more likely it is to have some more discomfort. So the transurethral resection of the prostate, this is what we consider to be the gold standard, because it's been done since the 1950s. And basically, it's the most effective, proven to work over time. So the way it works is that I go back to this picture here, but again, this is done in the operating room, and maybe a little bit difficult to see in the smaller picture, but there's the camera that goes in through the penis, through the urethra, into the bladder. Then there's a loop that's on the end of the instrument that actually can scrape away the prostate tissue and open up the passageway that way. So I would say, rather than usually outpatient, I would actually say that it's usually inpatient unless your prostate's very small. You do need a catheter sometimes for usually for a few days. It is done under general anesthesia. So again, I mentioned the ejaculatory dysfunction before with the laser. You're typically going to get that with a TURP, because again, it opens up the bladder neck. So when you have an orgasm, it can't close down to prevent the semen from going backwards. There's a low risk of erectile dysfunction. Probably only about 1 to 2% of people can have erection problems after this procedure. Because of the scraping of the prostate tissue, I usually want you to limit your activity for at least a couple weeks afterward, because the biggest risk from the procedure is having bleeding. And so want just taking some downtime to just let it heal, because the more active you are, the more likely you are to see some blood in the urine. Some people may have some burning with urination or urinary frequency just while it's healing, which I think usually it's for a few weeks. And tissue is removed and can be checked for cancer. Again, most of these procedures are not being done for cancer, but if there is any concern, if there's not a concern, we're still going to send the tissue so we can have it checked. So one of the newer treatments that's become available is something called aquablation. So aquablation uses a water jet. So it's kind of like a high pressure water jet that basically you program to go through the prostate tissue to remove it. So it's what we call surgeon assisted robotic technology. It does require general anesthesia, and it is an overnight hospital stay. So this is a picture of the machine. Basically, you take a camera, go in through the penis, you have an ultrasound into the rectum at the same time, and what you can actually do is by measuring and putting different markers on the prostate, you can actually program the machine in terms of how much prostate tissue to remove. So after this procedure, you may have some burning with urination. It should not affect erectile dysfunction or the retrograde ejaculation, because you can program it to actually preserve the bladder neck. And over 99% of men do not experience any kind of incontinence or urinary leakage afterward. I would say that's going to be true for almost all these procedures. So incontinence is not a big risk as far as I'm concerned. So if you have a very large prostate, you can still do an aquablation. You could do a laser, though I think that's going to be quite time consuming, and I'm not sure that's the best option. So another option you could do would be what we call a simple prostatectomy. It's called simple because, as opposed to radical is where you remove the entire prostate, and that's for cancer. This is just removing what we call the adenoma, or the benign portion of the prostate tissue. So you just remove the inside part of the prostate. Using robotic technology, we can do it with small incisions. It does make the recovery more quick. With small incisions, you're more likely to heal and get back to your normal activity sooner. It is done under general anesthesia, requires an overnight hospital stay, and usually we leave a catheter for about 7 days afterward. Now, typically this can cause ejaculatory dysfunction because, again, you're opening up the bladder neck to do this procedure. Erectile dysfunction has a low risk of this because you're not injuring the nerves, which are on the outside caps of the prostate. Again, we want to decrease your activity while you heal. You can see blood in the urine for a couple weeks. There can be a little bit of stress incontinence that can occur sometimes with this procedure because this is removing the most amount of prostate tissue. You can have some burning or frequency and urgency for several weeks just while it's healing. And because there's a large amount of tissue that's removed, we do send it for pathologic analysis. Okay, so I think we ran through many different treatment options. Those aren't all of them, but I think that those are the ones that we typically offer through the Michigan Institute of Urology. All the treatment options basically there's good and bad to all of them. All of them depend on your prostate size, your prostate anatomy. So one may be good for one person, not so great for the next person. But I think they can all be successful in the properly selected people. So if there are any other questions, please feel free to send them through the chat. Otherwise, we'll give it a minute or two and be sure to talk with your urologist about what treatment is best for you. Okay, so does an enlarged prostate add to erectile dysfunction? I say typically no. I would separate those two things completely separately. 2 prostate biopsies for 7 years because of an abnormal PSA, no problem found. Is this unusual? Not necessarily. I mean, it depends again on the size of your prostate and your PSA is. There's other tests that can look at your risk of cancer. So, but that is not necessarily unusual. Let's see. So, shorten up this one, but basically was evaluated a couple years ago, was planning to do Urolift, and then chose not to. Would you need to do all the tests again? It depends. So that depends when you say COVID hit. So if it's been 3 or 4 years, you may not have to do everything, but certainly the size of your prostate may have changed. Urolift, I think Urolift is okay for the right size prostate. I do not like Urolift if you have an enlarged median lobe, which is on the floor of the prostate. That's my personal preference on that. And I think that for smaller prostates, I think Urolift can still be okay. Can pumpkin seeds reduce prostate size? There's no documented data that actually shows that it does. Saw palmetto, randomized placebo-controlled trials have shown that saw palmetto does nothing. It's no better than a placebo. If you are interested in a supplement, the only one that has actually been shown to show some improvement is beta-cytosterol, which I think is in super beta prostate as well as other things. So beta-cytosterol would be something you can certainly look into if that's what you're interested in. If mass is present in the prostate, is this diagnosis more than BPH? I'm going to assume masses are guessing that that's probably based on exam. So that's difficult for me to answer because I don't know all the detail on that. But definitely I would talk to your urologist about that. Effects and side effects of 5-alpha reductase inhibitors in regards to cancer. So 5-alpha reductase inhibitors like Proscar and finasteride, so they do shrink the prostate. Some of their side effects, they can cause erectile dysfunction, they can cause decreased libido in about 7 or 8% of men. 1% of men can get gynecomastia or enlargement of the breast. There was one study initially that showed that if you are on those drugs for 10 years, that it could increase your risk of high-grade or aggressive prostate cancer. Subsequent studies showed that that was not the case, but it is still a black box warning. So I don't have an issue using it in terms of my concern for patients getting cancer on it, but I still think you need to follow your PSA and your exam to make sure nothing changes. Can you use Viagra when taking Flomax? Yes, but you're supposed to separate them by 4 hours because it can lower your blood pressure, make you lightheaded and dizzy. What medications have the least side effects, particularly with erectile dysfunction? So I would go with the alpha blockers because they shouldn't really affect the erections. Alfuzosin or uroxetrol does not cause retrograde ejaculation if that's a concern. How effective are the alpha blockers? Again, depending on size. If you look at what we call symptom score, alpha blockers will probably decrease your symptom score by about 7 or 8. The scale goes up to 35. So I don't know if that helps you in that sense. So, but I do think that they can certainly help, and that's the standard treatment. Does remove the prostate cause impotence? It can cause erectile. It can potentially cause erectile problems if you're doing it for cancer. We already talked about those. So if somebody asked, do those metal pieces remain inside? They do. But you can still go through, you can still have MRIs with them. They're made of titanium, so they're That's basically talking about the Urolift. So a couple questions on that. With aquablation, does the prostate tissue grow back? Not typically. The plan would be about I should tell people it's a 1% reoperation rate per year for life. So in 5 years, 5%, 10 years, 10%. If you're having side effects, can you try a different medication? I mean, the alpha blockers are all going to be similar. So if you're getting lightheaded and dizzy with one, you're probably going to get lightheaded and dizzy with all. Alphazocin does not have the retrograde ejaculation. So if that's the issue, you can change over to that. I don't think that the alpha blockers have significant ED as a side effect. There's no problem with opening up the bladder neck. It's just that what happens is that when you have an orgasm, the bladder neck closes. And so what that does is allows your semen to go forward. If you open up the bladder neck, it can basically make it so that way it's easier to urinate, but it can't close all the way down if you're having an orgasm. So if you still want children, which most men with BPH do not, then it's not a medical issue per se. It's just a ejaculation issue. Thoughts on the use of stents? There was a Uroloom that was out years ago, but that's taken off the market because it was terrible. There is a new one that is basically being studied called a butterfly. So that's still under trial. Otherwise, there's a iTin, which is new, which is really only good for very small prostates. Aquablation referred to large, definite large. Really, there's no upper size limit of normal for an aquablation, in my opinion. But it usually minimum of 50 grams. I mean, I've done up to about 225 grams, which is a huge prostate. 40 grams is a normal size prostate. Let's see. You can use alpha blockers with 5-alpha reductase medications. So another good question, using both tamsulosin and trospium. So are they treating the same condition? Not really. So tamsulosin is treating the bladder. Tamsulosin is treating the prostate and bladder neck. So what that's doing is that's helping the emptying ability of your bladder, whereas trospium, for those who don't know, but it's basically an overactive bladder medication. So that's acting on the bladder to help the storage function. So sometimes it can be difficult to sort these two things out between is it a prostate issue or a bladder issue. With the so the idea is that by improving your storage capacity, it can sometimes help with the frequency and the urgency, but you got to make sure you're getting your bladder empty. How's the TURP done? Prostate being outside the urethral wall? You just go through the urethral wall, and it heals on its own. It's not really an issue. To overcome your fear of procedures, I guess talk to your urologist, find out which one is best for you. There's lots of different options. And I would say if you have a lot of fear, sometimes doing things under anesthesia is probably a little bit easier. But I think that just the more informed you are, the easier it is to undergo. How do you determine when to proceed with surgery versus medical? Depends on a little bit on you, and it depends a little bit on medically. So if you're not emptying your bladder very well, despite taking medication, it's time to move on to something else. Prostate problems can sometimes show up when you're having a cystoscopy for bladder cancer. Peyronie's disease is not connected to BPH. So of the procedures, will the prostate grow again? So the ones that actually remove a lot of tissue, so the TURP, the Aquablation, the simple prostatectomy, those procedures are going to remove the most amount of tissue. Laser may or may not. I don't think it's going to remove as much, but those other procedures will actually remove the most amount of tissue, and it's the least likely that you would need a secondary procedure. So prostate should not necessarily grow back that much. If your doctor is retired, one of our partners should be able to see you and look at your other tests, and they can work with you on whatever is best for you. Urolift was in Europe for about 8 to 10 years before it came here. And it's been around probably 3-4 years, something like that, in the US. If you have mild BPH and erectile dysfunction, can you use Cialis? You can. So the 5 milligram daily Cialis can potentially treat the 2 birds with 1 stone, as they say. So it can do both. I would say that in terms of efficacy, so before I said the alpha blockers will give you about a 7 symptom improvement on your score. Maybe Cialis will give you a 4. The beta-cytosterol, the plant-based one, that's a supplement, it's maybe a 2, just to give you some kind of degree of improvement. But if you have mild symptoms with erections, then that is a good potential treatment option. It does not shrink the prostate, but it can help to actually relax the smooth muscle as well. Can Kegel exercises help with urinary leakage? It depends on what the cause is. So if your Kegel exercises help to tighten and strengthen the urinary sphincter, but if that is not the issue, so if you have overactive bladder or bladder spasms, and that's what's causing leakage, Kegel exercises probably aren't going to do very much. A good instructional source, I don't really have a good instructional source for you. Usually we would send people to physical therapy. There's the Lift program, for example, or other physical therapists. Usually we can help you with more than just Kegel exercises. And I believe that should be it. So thank you very much for your time. I hope I got to most, if not all, the questions. But again, the best way to make sure you're getting the right treatment and what's best for you, because each person's prostate is going to be different. Each treatment's going to be individualized. Talk to your doctor. Okay, so please feel free to call me or any of my partners. We'd be happy to take care of you. Thank you and have a good night.